We're going to have two chapters and two lectures on the renal system. The first one, covering chapter 18, we'll talk about basic renal functions. And the second lecture, covering chapter 19, we'll talk about some of these functions in particular detail with an emphasis on the homeostasis of mineral and water balance. That is, maintaining normal concentrations of various electrolytes, ions, minerals, whatever you'd like to call them, as well as water. But before we can understand that, we have to understand how the kidneys function. So the primary function of the kidney, or primary functions, there are several, is to regulate plasma ionic composition. That is the concentration of sodium, potassium, and other ions, as well as to regulate plasma volume. And of course, in this case, we're talking about the watery part of the blood, which of course is a fair proportion of the actual blood. Keep in mind, regulation of plasma volume is also controlling venous return to the heart. Going back to cardiovascular function. So the kidney is not only a highly vascular organ, as we'll see, but its function has direct impact on cardiovascular function. And of course, ion composition and plasma volume are related because the osmotic pressure produced by the various ionic concentrations will also, of course, affect plasma volume. So with that, we're also, those two things together, is affecting plasma osmolarity, that is, concentration of water versus the concentration of ions. Also regulating plasma pH, that is, acid-base balance. And of course, in this case, pH is due to protons, that is, hydrogen ions. So this is a special case of ion composition regulation, because hydrogen ion does affect acid-base balance, and acidity affects the function of many enzymes. And ultimately, what most people think of in terms of renal function is to remove metabolic waste products. But that is actually, while it's important, it is secondary to these other four functions. Secondarily, the kidney, remember, is a secondary endocrine organ. It secretes erythropoietin, which stimulates the production of new red blood cells. It secretes renin, which we'll talk about primarily in the next lecture. But renin is involved in the conversion of angiotensinogen into angiotensin 1. And we'll see later that angiotensin 1 gets converted into another substance called angiotensin 2, which affects blood pressure. Also, the kidney activates vitamin D3 into calcitriol, which is important for calcium homeostasis. And we'll talk about that in another chapter on the regulation of growth. And finally, gluconeogenesis, that is the production of new glucose molecules, which of course is going to affect energy supplies in the body. So let's take a look at a brief overview of the anatomy of the urinary system. The kidneys are the urine-producing portions of the system. The ureters transport urine from the kidneys to the bladder. So the ureters here, actually let me change color, it will show up better. So the ureters transporting urine from the kidney to the bladder. The bladder, which stores urine, so the bladder down here, which stores urine for later release. And the urethra, which carries urine from the bladder to the exterior of the body. So the anatomy of the kidney will be the most important part for our considerations. We have here a slice through the kidney, and looking at a portion of that slice. And we see these very convoluted tubular-shaped structures here. And each of those is what's called a nephron. So this is a single nephron here. The nephron is the functional unit of the kidney, by which we mean that every function that the kidney carries out occurs in each and every nephron. So basically, each nephron is like a microscopic kidney. So we're going to be talking mostly about structures within the nephron throughout the rest of this lecture. So a nephron starts here in Bowman's capsule. It's called the renal corpuscle, which Bowman's capsule is the yellow part here. The glomerulus is what looks like this sort of tangled mass of blood vessels that's inside Bowman's capsule. Blood comes in through the afferent arteriole, circulates around in the glomerulus, and then leaves through the efferent arteriole. And substances are filtered out of the blood into the space that's inside Bowman's capsule and then transported throughout the nephron, ultimately being collected into the collecting duct, which is going to bring the urine down to the ureter. So we're going to be talking a great deal about functions within Bowman's capsule and the glomerulus, proximal convoluted tubule, which is named such because it is the part of the tubule that is proximal to, that is close to the glomerulus. There's a convoluted part versus a straight part. Then there's what's called the loop of Henle, which consists of both a descending portion and an ascending portion. And then a thick limb of the ascending loop of Henle. And this terminates in what's called the distal convoluted tubule. So again, it's a convoluted tubule. In this case, it is further away in terms of urine flow, further away from the glomerulus than the proximal convoluted tubule. Of course, anatomically, they're equally similar in distance. We're talking in terms of the flow of the urine being produced. And as we'll see, there are specific functions that are uniquely carried out within the glomerulus, as well as the proximal convoluted tubule and the distal convoluted tubule, and even when we get into the collecting duct. So there are regional specializations within the nephron. These regional specializations are in part due to the blood supply, as well as also due to transport mechanisms and pumps that reside within the wall of the renal tubule. Let's take a look at the blood supply first of all. So I'm going to switch to black here because it's going to show up most well against all of these different colors. So you have blood, of course, coming from the heart through the renal artery. And this is going to branch off into the afferent arteriole. And it's afferent because it's going to the glomerulus. And then blood flow leaving the glomerulus through the efferent arteriole. So we'll be using that terminology quite a bit. The other thing that's important to notice is that after the blood leaves through the efferent arteriole, before it gets back to the venous collection, is this very dense network of blood vessels, a lot of which we refer to, or a major portion of it, which we refer to as the vasa recta. That is peritubular blood vessels, which of course there's also some up here in the proximal convoluted tubule and the distal convoluted tubule. But generally, we refer to the term peritubular capillaries out here in the renal cortex, so the upper portion of the nephron, whereas the vasa recta occurs down here in the renal medulla, which surrounds the loop of Henle. So there are four basic processes in the kidney. These are filtration, reabsorption, secretion, and excretion. Filtration is, as the name suggests, the filtering out or removal of material from the blood within the glomerulus. We have blood flow coming in here through the afferent arteriole. Blood circulates through this dense capillary bed, And as we saw when we talked about capillaries in the systemic circulation, of course, there is filtration going on. Shown here, it's removal of material from the blood into the renal tubule. And this is, of course, the beginnings of the production of urine. So this is filtration from the glomerulus into Bowman's capsule. So we actually have molecules, ions, what have you, that filter out across the capillary wall, end up in the space here in Bowman's capsule, and then, of course, get carried along down through the renal tubule. Some of that material needs to be preserved, such as glucose. Most of the glucose that's in the blood gets filtered out, and we want to reclaim it. Otherwise, we'd, of course, have to consume a lot more glucose in our diet to make up for our energy needs. Other substances, sodium, potassium, and the like, that get filtered out end up being reabsorbed. Reabsorption occurs after the Bowman's capsule and glomerulus from the renal tubule into these peritubular capillaries. Keep in mind, this is not the same thing as absorption. Absorption refers to taking something out of the bloodstream for the first time. So absorption occurs in the gastrointestinal tract. In this case, this is material that was absorbed in the digestive tract, was filtered out of the blood, and now is reabsorbed, hence the name. Some materials can't be filtered out, and they need to be secreted. So we actually have pumping systems that remove substances that never were filtered out of the blood, and these are secreted from the peritubulary capillaries into the tubules. Ultimately, all of this together produces excretion, which is the bulk flow of urine from the tubules out of the body, into the bladder, and then ultimately out of the body. So we're going to spend a great deal of time talking about filtration, reabsorption, and secretion. Filtration involves a bulk flow of plasma. We have a large quantity of plasma coming in through the afferent arteriole. And again, this is a very convoluted tangle of capillaries in here, so the blood spends a lot of time traveling back and forth through the glomerulus before exiting out through the efferent arteriole. These glomerular capillaries have fairly specialized structure, as shown here. This is the capillary here, and outside of it are epithelial cells that are referred to as podocytes, because they have foot-like structures coming off here that interdigitate. So you actually have several podocytes that send these processes out along the capillary, and the fingers from this podocyte interdigitate with the fingers from other podocytes that are also located on the capillary. And these basically form a meshwork through which materials have to filter. So there's a movement of protein-free plasma, that is, plasma and electrolytes, glucose, a variety of what we call solutes, filter out. The protein does not. The protein, of course, stays within the bloodstream itself. And this filters from the capillary into Bowman's capsule. That is, this area, this free space that is surrounding the capillaries outside of Bowman's capsule, and ultimately funnels that material down into the proximal tubule. The rate of filtration, or what's called the glomerular filtration rate, or GFR, is about 125 milliliters per minute. Now that amounts to 180 liters per day. Now nobody, and this is a big exclamation point here, nobody urinates 180 liters in a day. That is because a great deal of reabsorption occurs to reabsorb much of that plasma and other material that was filtered out. Before we talk about reabsorption, let's finish up talking about filtration. So we talked about Starling forces in terms of systemic capillaries previously. We have to talk about it again. But in this case, it's at least not new material. So there is a hydrostatic pressure within the glomerular capillary. It is, of course, the fluid pressure, hydrostatic meaning fluid pressure. It's due to blood pressure primarily, of the fluid within the glomerular capillary that favors filtration. It's a fairly large force here, favoring the movement of water and other molecules out of the capillary into the space of Bowman's capsule. And this is abbreviated as a large uppercase P with a GC for glomerular capillary. There is, of course, a hydrostatic pressure within Bowman's capsule itself. Its abbreviation is the uppercase P as well, with a BC rather than a GC. So this is shown here. As fluid filters out from the glomerulus into Bowman's capsule, of course, it builds up a certain amount of hydrostatic pressure that pushes back. So these two pressures, of course, tend to oppose each other. They're not equal in magnitude, but they are opposite in direction. Now, within the glomerular capillary, of course, we have oncotic pressure, which is due primarily to the proteins. And keep in mind that in filtration, proteins do not get filtered out of the glomerular capillary. In fact, the only time protein ends up in the urine is if somebody has damage to the integrity of the nephron, in which case is generally kidney failure. Oncotic pressure, if you recall, we use the Greek letter pi, which of course is the equivalent of the P. So the glomerular capillary pressure, which is shown here, and of course because this is protein, remember water tends to flow toward where protein is most highly concentrated. So the glomerular oncotic pressure is actually a force pulling water back into the glomerular capillary from the space in Bowman's capsule. And then, of course, there is an oncotic pressure within Bowman's capsule. That is a Bowman's capsule oncotic pressure. Again, use the Greek letter pi. And, of course, in this case, there is some protein here. As I said, protein is not normally going to be filtered out of the blood, but there is protein elements within the tissue of Bowman's capsule. And this, of course, works to pull fluid from the capillary into Bowman's capsule. So just as we saw before in terms of the Starling forces, you have two forces that tend to attract water or push water from the capillary into Bowman's capsule. And you have two other forces that pull fluid or push fluid back in. All of this is filtration. The net result is filtration. Do not think of these forces that are moving material back into the blood as being reabsorption. That is a very different process. In fact, it's an active process. So with this, there is actually what we call glomerular filtration pressure, which is, of course, the algebraic summation of all four of these pressure components. And it ends up being about 16 millimeters of mercury favoring filtration, favoring the largest vector here. So if we're talking about Starling forces, remember this diagram came from previous lecture and chapter covering the cardiovascular system. So these are the same forces that we learned about in chapter 14, and these are at work in the glomerulus. In fact, I personally think it's a little bit easier to understand them in the glomerulus than it was when we talked about systemic capillaries. But this particular diagram coming from the systemic circulation, I think makes it a little bit easier to visualize how these different forces work than this sort of tangled mass of capillaries that we have over here in the glomerulus. So Starling forces favor filtration. We saw that on the previous slide. So filtration, the forces that are definitely directly contributing to filtration is the capillary hydrostatic pressure, which is about 60 millimeters of mercury. And this is high due to the resistance of the efferent arteriole. And the efferent arteriole's smooth muscle contraction or resistance is regulated as a way of extrinsic regulation of filtration. Bowman's capsule oncotic pressure, which is generally zero because there is so little protein within Bowman's capsule, as well as within the filtrate itself. So we generally, it's safe to assume in this case we have 60 millimeters of pressure, because 60 plus 0 is of course 60. Favoring absorption, the hydrostatic pressure in Bowman's capsule, which is only about 15 versus the 60 in the capillary. So, of course, that means that it's favoring movement out of the capillary into Bowman's capsule. And this pressure is relatively high compared to systemic capillaries due to the large volume of filtrate. So we have a lot of filtration going on here that is pumping water from the capillary into Bowman's capsule. And of course, there's a certain amount of damming up of that water as it gets funneled into the tubule. Then the glomerular oncotic pressure, which is about 29 millimeters of mercury. And of course, this is due to the proteins within the bloodstream, within the blood supply, within the glomerular capillary. So water gets filtered out by hydrostatic pressure, but then tends to get pulled back in due to this oncotic pressure. And again, it's the net filtration that we're interested in. That overall you have 60 versus 44, because 15 and 29 equals 44. So we have this net difference of 16 millimeters of mercury favoring filtration. So that's shown again here diagrammatically. We have our glomerular capillary hydrostatic pressure, Bowman's capsule oncotic pressure, both favoring movement of fluid from the blood into Bowman's capsule. We have the Bowman's capsule hydrostatic pressure and the glomerular capillary oncotic pressure, both of them favoring movement of fluid and material back into the circulation. And because 60 is bigger than 44, we have a net pressure difference of 16 that ultimately favors the removal or filtration of material from the blood supply, from the capillaries, into Bowman's capsule. So with this, we refer to the idea of a filtration fraction, that a certain fraction, a certain proportion of the material in the plasma gets filtered out. As well as there is what's called, we've already talked about, the glomerular filtration rate. So let's see how they are similar and different. About 625 milliliters of plasma enters the kidney each minute. But only about 125 milliliters of it is filtered into Bowman's capsule. This we refer to as glomerular filtration rate. But that is about 20% of the total blood supply going into the kidney. So we refer to this as the filtration fraction, that normal glomerular filtration rate gives us a 20% filtration fraction. That is, only about 20% of the material coming into the kidney is filtered out at any given time. This also leads to the idea of a filtered load. Just like when we talked about skeletal muscle, the load is the amount of effort that needs to be conveyed, or the amount of work that needs to be done, amount of material that needs to be moved, if you will. So the same idea is relevant to the kidney, that we have a certain load of material, a certain amount of material that has to be removed from the blood supply. So filtered load is the glomerular filtration rate times the plasma concentration. So let's take a look at some of the factors that affect the filtered load. Small molecules are filtered without any impedance or resistance. They're freely filterable because they're so small. They fit through the slits between the podocytes in the glomerulus, and a great many of them are filtered out. And of course, it's not only in that case going to be due to the pressure gradients we talked about before, but if it's very highly concentrated, it's going to also facilitate the movement of those molecules. So the quantity that's filtered out is what we mean by the filtered load, and it depends upon the plasma concentration of that solute. So suppose we're talking about glucose. Again, keep in mind, if you have to go back to the lab on movement of materials across cell walls or across membranes, the solute are the electrolytes, glucose, etc. It is the stuff that is dissolved in the plasma. Solvent is the plasma. It is the fluid in which the solute is dissolved. So filtered load of glucose. GFR is about 125 milliliters per minute. We said that already. Plasma glucose concentration is about 100 milligrams per deciliter. So about 1 milligram of plasma in a milliliter of blood. That's converting 100 milligrams per deciliter into milligrams per milliliters. So the filtered load of glucose is our GFR, 125, times the plasma concentration of glucose, which is about 125 milligrams per minute of glucose gets filtered out. Now, of course, generally very little glucose ends up in the urine because most of it gets reabsorbed, but it gets filtered out initially. So let's see how GFR is regulated before we go on to talking about reabsorption. So as I said before, GFR, we have about 180 liters of fluid that's filtered out per day, but only about 1.5 liters ends up in the urine. This is less than 1% of the total amount of material that's filtered out. So 99% of the filtered fluid is reabsorbed. Again, keep in mind, you don't urinate 180 liters per day. You only urinate about 1.5 liters per day. And that's because there's a tremendous amount of reabsorption going on. But a small increase in GFR can produce a large increase in the volume of fluid that's filtered out. And GFR is highly regulated by both intrinsic and extrinsic mechanisms. Intrinsic mechanisms include myogenic regulation, and we've already talked about how the smooth muscle in blood vessels contracts in response to stretch. The same thing happens within the renal tubule as well as in the, I shouldn't say renal tubule, within the capillaries within the glomerulus, and what's called tubuloglomerular feedback. Now keep in mind the name, tubuloglomerular. It's feedback from the tubule to the glomerulus. Now, it's intrinsic because, of course, they're both occurring within the glomerulus and Bowman's capsule. Extrinsic mechanisms, largely blood pressure, which can have several types of effects that we'll talk about in a few moments. So let's look at myogenic regulation. There is smooth muscle in the wall of the afferent arteriole, and it contracts in response to stretch, which is what we call the myogenic response. We talked about it back in the cardiovascular system. So here we have an increase in pressure, mean arterial pressure in the afferent arteriole. So this increases the pressure within the arteriole. This is going to do several things. The immediate thing is that it's going to increase glomerular capillary pressure, which, remember, this is also hydrostatic pressure. And that in turn will increase glomerular filtration pressure, which of course will increase glomerular filtration rate. But due to myogenic autoregulation, the stretch here of the smooth muscle causes it to constrict. The constriction of the smooth muscle increases the resistance, which of course decreases glomerular capillary pressure. This is negative feedback for this increase that we would have seen otherwise. So because of myogenic regulation, an increase in blood pressure does not always produce an increase in GFR because of this negative feedback loop. Tubuloglomerular feedback is a bit more complicated. Let's jump ahead first of all and look at what's called the juxtaglomerular apparatus. So this is called juxtaglomerular because here is the glomerulus. All the glomerulus here. And it is located right next to it. Now the specifics of it are, here's your afferent arteriole. Of course, this is the glomerulus over here. Here's the efferent arteriole. And the juxtaglomerular apparatus is a massive tissue that because it's right next to the glomerulus, is called the juxtaglomerular apparatus or glomerular cells. And another part of this is also within the tubule itself. These cells, which are adjacent to the juxtaglomerular cells, called the macula densa. So both of these groups of cells are going to play a role in tubuloglomerular feedback. So the macula densa cells that we just talked about, again, these are the cells that are located here. These are in the renal tubule, but they are adjacent to, right next to, the blood supply coming into the glomerulus. And these secrete a paracrine in response to an increase in the flow of the fluid past them. So as there is greater filtration, of course, ultimately there is going to be greater fluid flow from that filtrate that's coming through the renal tubule. And these cells are responsive to that change in flow. So they secrete a paracrine. At this time, we do not know what the chemical identity of it is. And this is in response to an increase in flow, and it causes the smooth muscle of the arteriole to contract in response to this. So again, this works as negative feedback, that we have, in this case, an increase in mean arterial pressure, increasing the pressure within the afferent arteriole. Now, on its own, again, that would increase the glomerular capillary pressure or hydrostatic pressure, which of course increases the glomerular filtration pressure and which would increase the glomerular filtration rate. As more material is filtered out, there's going to be greater flow through the macula densa. Let's jump ahead to this picture again. So more material getting filtered out here in the glomerulus. So it's going to be traveling through the proximal tubule, loop of Henle, coming back up around here through the distal convoluted tubule, coming right through here. And these cells respond to that flow. By releasing this paracrine that causes the arteriole to contract, the afferent arteriole here now is going to contract down to a smaller diameter, which of course will reduce the hydrostatic pressure here in the glomerulus, which of course is a primary driving force for filtration, which means that ultimately there will be less filtrate, less urine being produced to end up flowing up through the distal tubule. So what happens here is that the paracrine causes this constriction within the afferent arteriole, which increases the resistance, decreasing the capillary, glomerular capillary pressure, which of course is negative feedback against this increase. So by doing this, this paracrine secretion ends up reducing urine flow. And of course, it is the urine flow initially that is causing the release of this paracrine that is then feeding into this negative feedback. So remember, that was intrinsic control. Now let's look at extrinsic control of glomerular filtration rate. First of all, glomerular filtration rate has a complicated relationship with mean arterial pressure. Between 80 millimeters of mercury and 180 millimeters of mercury, which is relatively normal. Now, 180 is obviously above normal, but 80 is on the low end of normal. And, 100 is, which is considered normal blood pressure, is about here. But within this range of between 80 and 180 millimeters of mercury, glomerular filtration does not change. It drops off below this range of pressure, and it increases above this range of pressure. But the reason that it does not change, even though there is a 100 millimeter of pressure difference across this range, is due to some various mechanisms. Some of it is due to the intrinsic regulation we talked about before, as well as extrinsic regulation. So a decrease in blood pressure can decrease GFR directly. In this case, an increase in blood pressure can increase GFR directly here, because it's either decreasing filtration or increasing filtration. But it is this autoregulatory zone in between that is due to the tubuloglomerular feedback that we talked about before. Now, blood pressure can also have indirect effects through extrinsic controls, whether or not blood pressure is decreasing or increased. Both of them will affect GFR through some extrinsic controls. These are renin. Renin is released by the granular cells of the juxtaglomerular apparatus. So let's go back here on a slide. These granular cells here that wrap around the afferent arteriole, these cells release renin. And we'll talk about that in a moment. And then, of course, the sympathetic nervous system. So now let's take a quick look at renin. You're going to see this again, but I want to talk about it more since I brought it up. I mentioned in a previous slide that angiotensinogen, start over again. Angiotensinogen is a protein that's released from the liver. Renin is an enzyme that breaks angiotensinogen down into angiotensin 1. Angiotensin 1 will be converted into angiotensin 2. By an enzyme we'll talk about later called angiotensin converting enzyme, or ACE. So renin catalyzes this initial part of this reaction. Angiotensin 2 increases blood pressure as well as stimulates thirst, which of course will increase plasma volume, which will also increase blood pressure. So renin, even though it's released by the kidney, because of its effect on these chemicals outside the kidney, contributes to extrinsic regulation of GFR. Take a look at the sympathetic nervous system. So in this case, suppose we have hemorrhage or sweating. Either way, we are decreasing blood volume, decreasing plasma volume. So this decreases blood volume, decreases venous pressure. If you're decreasing venous pressure, you're decreasing venous return to the heart, which will decrease cardiac output, which will decrease mean arterial pressure. A decrease in mean arterial pressure is going to stimulate the baroreceptors, which will increase sympathetic nervous system activity. Now, this is going to do a variety of things, of course, to the cardiovascular system, but since we're talking about the renal system, we'll focus on that. This will increase renal sympathetic nerve activity, which will cause vasoconstriction within the kidney of the afferent and efferent arteriole. Now, I realize this flow chart's a little hard to see on this slide, but if you look at page 521 in your textbook, figure 18.12, it's the same figure. So the vasoconstriction within the kidney, well, same thing that the sympathetic nervous system does to other blood vessels, causes vasoconstriction, so there's nothing new there. This, of course, is going to increase renal vascular resistance. Well, that is going to increase, in part, total peripheral resistance, which will increase mean arterial pressure. So that's a negative feedback to offset the decrease that we saw in the first place. Also, this increase in renal vascular resistance will, of course, reduce blood supply to the kidney, so it will decrease glomerular filtration rate, which will decrease urine flow. By decreasing urine flow, we've decreased fluid loss. Well, this is going to offset the decrease in blood volume that started this whole process going. So we have a couple of different examples of negative feedback here. And in this case, also a direct effect from the standpoint that the decrease in blood pressure is decreasing the hydrostatic pressure going to the nephrons, or going to the glomerulus, which is also going to decrease glomerular filtration rate. So sympathetic nervous system has some very complicated effects. It's not as complicated so much as it's hard to understand, but that there are numerous aspects to the effects that the sympathetic nervous system can have on GFR. Well, I kept talking about the fact that we're going to get to talk about reabsorption eventually, and here we go. Reabsorption is selective. We're transporting, so I have to go back to some of the earliest material in the textbook, material that we actually have not talked about in any detail in this course because it has material that was covered in prerequisites. But the idea of transport, we had this covered in some of your labs, the idea of active transport and passive transport. Reabsorption, for the most part, is due to active transport or facilitated passive transport, but it is selective. Not everything that gets filtered out gets reabsorbed. And of course, it's movement of material from the renal tubules into the interstitial fluid surrounding the renal tubules, and then ultimately into the peritubular capillaries. Peritubular capillaries, the vasa recta, etc., and ultimately return to the blood. Most of it occurs in the proximal tubule, which makes sense. We've just finished filtering out a great deal of material in the glomerulus, and now we are going to reabsorb most of that important material that we want to conserve, such as glucose. Most of it, however, is not regulated. So most reabsorption is occurring in the proximal tubule, and most of it is not regulated. And what happens here is that we have, in this case, this is the lumen of the tubule here, that there are epithelial cells within the tubule that have tight junctions, and that means that most material cannot actually move between the cells. We have to have transport through the epithelial cells. But this is, of course, the process of reabsorption. So this chart, again, a little hard to see, but if you go to page 522 in your textbook, what you'll see is water, glucose, urea, sodium, potassium, calcium, chloride, and bicarbonate. The amount that is filtered during the day, the amount that's reabsorbed. And what you see here is, first of all, that 99.2% of water is reabsorbed. Remember, we said we filtered out 180 liters per day, but only urinate about 1.5 liters per day. Well, that's the 99% that's being reabsorbed is what is responsible for this. But let's look at glucose. It's very important. Glucose is actually 100% reabsorbed. Now, this is assuming a person doesn't have diabetes, in which case urine will contain glucose. But if you think about it, glucose, first of all, is what we call freely filtered. That is, just about all the glucose that's in the blood ends up being eliminated, but all of it that gets filtered out gets reabsorbed. Well, why would you do that? Well, glucose is a source of energy, and it makes more sense to reabsorb the energy molecules that you've just filtered out than to eliminate them in the urine and end up having to consume more of them. If you notice, too, that most of these other substances are about 99% reabsorbed. The only one that has a fair appreciation or significant amount that ends up not being reabsorbed is urea, in which case we're still reabsorbing about 50% of it. And we'll see that this plays a significant role in the next chapter, in the next lecture, on the osmotic gradient at the loop of Henle that is in fact involved with some of the reabsorption that's going on. So the important thing here is that there's a tremendous amount of filtration going on for many of these vital substances, except for urea, which of course is a waste product. But these are all molecules that are vitally important for normal biological, physiologic function. Most of it gets reabsorbed. So it underscores the point that reabsorption is actually very important. So let's look at reabsorption. First of all, as I said, solute, go back to this slide. With the exception of water, all of these are solutes. Water, of course, is a solvent. Again, going back to the lab on osmotic pressure, if you're uncomfortable with this concept, you should really revisit that lab and think about it again. So we reabsorb water as well as solutes. And as I said, most occurs in the proximal convoluted tubule right after it's being filtered out. A lesser amount in the distal convoluted tubule. Some of the reabsorption is active, meaning we have pumps that are using ATP as an energy source, and some is passive. In that case, most of it is facilitated diffusion, but we'll talk about that in more detail a little later on. And there is a barrier for reabsorption. That is the epithelial cells of the renal tubules as well as the endothelial cells of the capillary. Now, within the capillary, this is a minimal barrier. But the idea of the barrier, just as we saw in the pulmonary system in terms of the barrier for gas exchange, it is minimal, but it's nevertheless there, and it's something you need to keep in mind, that it does have some effect. Let's look at active reabsorption of solute. So we're talking now not about water, but we're talking about solute. Here we have the lumen of the renal tubule, the epithelial cells lining the wall of the renal tubule, the peritubular fluid or interstitial fluid, if you will, capillary endothelial cells, and then of course the plasma. And some substances are transported by pumps on the apical membrane of the epithelial cells. And these then, of course, have to be pumped into the cell and then pumped out to go across into the capillaries. And this is active solute reabsorption, meaning that these are pumps that are using ATP. And most of the sodium that got filtered out does get reabsorbed here in the proximal convoluted tubule by active reabsorption, and glucose as well. All of the glucose gets reabsorbed. In addition to active reabsorption, there is passive reabsorption. And in this case, we have a high concentration of substances. These substances are urea, chloride, potassium, bicarbonate, and some of the sodium. Remember, most of it was absorbed actively already. There is some passive absorption. That's just substances moving down their concentration gradient. Reabsorption of water. And of course, keep in mind, water is the solvent. This is due to the solutes we've talked about before in the previous slides being pumped down, and this is changing the osmotic pressure gradient. So this is actually osmosis. Water molecules following these solute molecules. This is what's called solvent drag. That actually is the solute moves along, moving down its concentration gradient. It pulls the water down its concentration gradient along with it. Now, for those substances that are actively transported, we need to address the idea of a transport maximum. That is when the carriers, the transport pumps, are saturated. So when a solute is transported across the epithelium by a carrier protein, saturation of the carriers can occur. This can happen in glucose. So we'll use that as an example. If you have a solute such as glucose, that's normally 100% reabsorbed. And of course, glucose is definitely, again, unless there's a disease, 100% reabsorbed. If you saturate the carriers, then some of that solute is going to get excreted in the urine. And that's what happens in diabetes, is that because the blood sugar is so high in diabetics, that the glucose transporter that reabsorbs the glucose back into the blood gets saturated. So some of those glucose molecules can't bind to binding sites on the glucose pump, and therefore the glucose stays in the urine. So the solute in the plasma that causes the solute in the filtrate to saturate the carriers and spill over into the urine. We refer to this as the renal threshold, and generally it's going to have a numeric value related to the concentration of that substance. So let's look at glucose. It's freely filtered from the glomerulus. That means just about all of it is removed. And normally about 100% of it is actively reabsorbed, meaning, of course, there's pumps that are using metabolic energy, and therefore no glucose remains in the urine normally. So let's take a look at how glucose is transported. There's actually a co-transport of sodium and glucose. So we actually have here is sodium moving down its concentration gradient, is driving this pump to pump glucose down. And then there are different exchange pumps here for glucose versus, say, sodium, potassium, ATPase, our old friend, that is involved in reducing the sodium concentration within the cell. Therefore, sodium is constantly moving down its concentration gradient. So these carrier proteins right here, these pumps for glucose reabsorption, it's secondary active transport. It's secondary to, of course, the movement of the sodium, and sodium is being actively pumped here by the sodium-potassium ATPase. And here, the glucose is moving by facilitated diffusion. So what happens if the binding sites for glucose on this pump get saturated? Well, then some of that glucose isn't going to end up getting pumped back into the blood. Some of it's going to stay in the urine. So let's take a look at this quantitatively. The amount of glucose that gets filtered out is directly proportional to the plasma concentration of glucose. And here we're looking at the rate of movement of glucose. So what this means is as greater glucose concentration, more of it's filtered out. Makes sense. Things moving down their concentration gradient. But what you find is that in terms of the urine, there is no glucose in the urine until you get to about 300 milligrams per deciliter. Now keep in mind the normal non-diabetic glucose concentration in the blood is about 100 milligrams per deciliter. It might go up to something around 170, 180 right after a meal, but it goes back down. But as more and more glucose in the blood in a diabetic individual start saturating these transporters, and then you end up starting to find glucose in the urine. Now this line here that says renal threshold is because at about 150 milligrams per deciliter, we start saturating the transport pumps. We start saturating these transport pumps for glucose. So that's the renal threshold we're referring to here. So what we see is right after that threshold, there are small increases in glucose in the urine. But once we get past this point here, which is our maximum, this is the beginning of saturation. At this point, about 325 milligrams per deciliter, we have fully saturated these pumps. And that is when we start seeing the amount of glucose in the urine paralleling plasma concentration. So a given amount of an increase in glucose in the urine or in the blood produces an equivalent increase in the amount of glucose that's being excreted. And that is because you take a look at this other curve, that most of this is being filtered out here, is being reabsorbed. But once we get to this saturation point of the pumps, you can no longer reabsorb any. That's what we're showing here is this maximum transport, that something just under 400 milligrams per minute, which corresponds with this about 325, 330 milligrams per deciliter. At this point, we have saturated all of these pumps so that we cannot bring this glucose back into the bloodstream. So that's why that glucose ends up directly in the urine. Now this is just using glucose as an example, and it explains why glucose ends up in the urine of diabetics. This, of course, will happen with anything else that's reabsorbed as well. It's just it's easiest to understand in the case of glucose because it is normally completely reabsorbed. Now with that, we have the term renal handling of glucose, meaning how does the kidney process glucose? Well, the plasma concentration of glucose normally is about 100 milligrams per deciliter. And we've already talked about the filtered load of glucose is about 125 milligrams per minute. So the transport maximum for glucose is about 375 milligrams per minute. Let's go back to this curve. This is about 375 milligrams per minute. So the theoretical renal threshold is about 300 milligrams per deciliter, which is the GFR times the renal threshold, gives us our theoretical transport maximum, which is right here. It's this line right here. But the actual renal threshold is actually lower. It's substantially lower. It's almost half as much. It's 160 to 180 milligrams per deciliter. And the filtered load in that case is about 225 milligrams per minute. And that is because, of course, the renal threshold, we're starting to saturate some of the transporters here. Versus out here, the theoretical is when they're fully saturated. So this finishes up the discussion of reabsorption. Now let's talk about secretion. In this case, the solute is moving from the peritubular capillaries into the tubules. We're taking material out of the bloodstream and putting it in the urine. And this is material that had not been filtered. This is material that stayed in the bloodstream and now is being eliminated. So none of this material is, of course, going to be biologically important. And that's why the system is eliminating it, and it's through the process of secretion. The barriers are the same as we talked about for reabsorption. And we also have the same transport mechanisms, but they're in the opposite direction, because in this case we're taking material from the urine and putting it, from the blood and putting it back into the urine. The substances that are secreted are potassium, hydrogen ions, choline, creatinine, penicillin. Of course, penicillin is not normally present in your body, but it is important to keep in mind that drugs such as penicillin get secreted, which helps to reduce the plasma concentration of them. So now let's take a look at some of the regional specialization within the tubules. As I said at the outset of this lecture, some regions of the tubules perform certain functions. As we've seen, some are involved in reabsorption, some are involved in secretion, and some are involved specifically in either reabsorption or secretion of specific solutes. Or, in fact, as we'll see especially in the next chapter, for solvent. That is parts of the tubule that are specialized for the reabsorption of water. So, specific regions perform specific functions. There is non-regulated reabsorption in the proximal tubule, and there is regulated reabsorption and secretion in the distal tubule and in the collecting duct. And water conservation, and we'll see this in greater detail in the next chapter, next lecture, water conservation in the loop of Henle. The loop of Henle is crucial for reabsorbing that 99% of the water. Any water that was not reabsorbed within the proximal tubule, most of it's going to get reabsorbed in the loop of Henle, and a little bit more is going to be reabsorbed in the distal tubule and collecting duct. But it's the loop of Henle that really is going to be taking out a great deal of water from the urine. So the proximal tubule. First of all, we have what's called leaky tight junctions. These are tight junctions between the epithelial cells that are not do not fully prevent the material of substances between them. So we have some movement of material between the epithelial cells and then some that is transepithelial transport. But the proximal tubule is called a mass reabsorber because 70% of the water and sodium that gets reabsorbed right here in the proximal tubule. It has what's called a brush border. If you notice all of these convolutions on the membrane here, this provides for a very large surface area, which of course is going to aid reabsorption. Larger surface area means greater ability to absorb material. And a lot of it is non-regulated, and this is due to these leaky tight junctions. they allow what's called paracellular, that is, movement around the cells. And of course, with that, you can't regulate it very well. It's just the fluid that sort of works its way in between the cells. Regulated transport would generally require movement across the epithelial cells, and of course, that's not happening here. The distal tubule and the collecting duct. First of all, you don't have the same sort of brush border. While there's some convolution in the membrane, it's a lot smoother than it was in the proximal tubule. And we have, in this case, tight junctions. The material can't move between the cells. It's going to have to move across the cells. And therefore, it's regulated. Whenever you have movement across the epithelium, generally that means that there are pumps and other proteins that are actually regulating the transport. And the tight junctions, as I said, limit the paracellular transport. So I mentioned already that the loop of Henle is involved in water conservation. It basically concentrates the urine. And it's not so much the need to concentrate urine. In fact, as we'll see in the next chapter, in the next lecture, there's a certain minimal amount of water that we need in the urine. Otherwise, we would be trying to excrete some sort of a pasty substance, very much like the excrement of birds. What we want to do is to minimize water loss. And in so doing, the loop of Henle will concentrate the urine. So this is just a general summary in terms of the segments of the tubule, proximal convoluted tubule, the descending limb of the loop of Henle versus the ascending limb, the distal tubule, and the collecting duct. And as we see here, the substances that are being reabsorbed versus those that are secreted. Well, first of all, most everything that's going on in all of these levels of the tubule is reabsorption. There's a lot more reabsorption going on than there is secretion. All of the water that's listed here is being reabsorbed. The only thing that's being processed at all in the descending loop of Henle is water, and of course it's being reabsorbed. There's of course water reabsorption in the proximal tubule as well, and the distal tubule, and in the collecting duct. But the idea here is that the descending limb of the loop of Henle, the only purpose it serves is for reabsorption of water. And substances that are secreted, well, largely it's hydrogen ion here, here, and here, and some potassium. But of course, hydrogen ion is a byproduct of metabolism, and it would disturb acid-base balance if we retain too much of it. Now, ultimately, we have these processes of filtration, reabsorption, and secretion. Remember, the fourth process in renal function is excretion. And excretion, of course, is the end result of filtration, reabsorption, and secretion. So the excretion rate, that is how much urine is excreted in an amount of time, and as well as the amount of the substance that is in that urine, the amount of solute that is in that. It's the sum of the amount that gets filtered out, as well as the amount that gets secreted, minus the amount that was reabsorbed. And of course, the amount that's excreted depends upon the filtered load, how much was there to get filtered out in the first place, how much secretion is going on, what's the rate of secretion, and what is the rate of reabsorption that is reabsorbing this amount that was filtered out in the first place. So we'll revisit these basic renal processes again. We're going to do it a little bit more quantitatively at this point. Now, don't worry, I'm not going to be asking you to solve equations and come up with values here. But clinically, you're not going to be dealing with these processes in just an abstract sort of conceptual way. You're going to be dealing with them in terms of actual measurements. So you need to get some sort of exposure to that. So again, we have our filtration, our reabsorption, and our secretion ultimately resulting in excretion. And what we're doing here is looking at how these processes work quantitatively. So we have our pressure of water going on here in terms of the Starling pressures, and concentration, in this case, concentrations of solutes and solvents shown here. So the amount of solute filtered is about 12 millimoles, which of course then with water is a solvent. We have about 150 milliliters. Now we're dealing with solute. Remember, millimoles is not a concentration. That would be moles per liter or moles per milliliter. Millimole is an actual measurement of an amount of material. So we're talking about the amount of solute and the volume or amount of water. So we have a fair amount that's filtered. Water is not secreted. Water is filtered and then reabsorbed. We have solute that is filtered. We have additional amount that is secreted, and then some reabsorption. So what we're doing here is looking at how each of these processes, filtration, secretion, and reabsorption, are going on quantitatively, and ultimately how that affects the excretion. So we end up with, in this case, 9 millimoles of solute in 5 milliliters of urine. Now, this is a way of introducing you to the concept of clearance, which, first of all, it is a clinical concept. It is not something that is generally used in basic physiology. But again, you need to have some exposure to it because of its clinical relevance. So clearance is the volume of plasma from which a substance has been removed by the kidney in a unit of time. Another way of viewing it is the volume of plasma that contains the amount of a substance that was excreted. So clearance is a quantification of excretion. Going back here, we're talking about excretion, but clearance is basically the quantification of that excretion. So the calculation of it, and again, I'm not going to ask you to solve this in an exam, but you need to be familiar with the concept. The clearance equals the excretion rate. Going back what we saw here, the excretion rate divided by the plasma concentration of the substance. So we have here the concentration of that substance in the urine times the volume of the urine divided by the concentration of the substance in the plasma. Excuse me. Now, your book has a fairly lengthy and detailed description of examples of clearance, which I've summarized in this one slide. But basically, clearance is used, again, clinically to measure renal processes. So if you wanted to measure a patient's filtration or glomerular filtration rate, you would look at inulin clearance. Inulin is a starchy substance. Actually, it's a fiber. It's a dietary fiber. If you take a look at a lot of yogurt containers, you'll see that it has inulin in it. It's a thickening agent. But it is filtered, and it is neither reabsorbed nor excreted. So if you measure the amount of inulin that's cleared, you have a very good measurement of filtration because it is filtered but not reabsorbed and not secreted. Thing is, you have to administer inulin to a patient. So a technique that is used generally instead is to use creatinine clearance. Now, creatinine is a substance that our body produces. There's always a certain amount of creatinine being produced, largely from muscle metabolism, etc. But that way, you don't have to administer it to the patient. It's there. The problem is that it overestimates GFR because a small amount of it is secreted. So creatinine clearance will give you a higher value of GFR than inulin clearance will. So if a patient has reasonably normal creatinine clearance, you don't need to consider using inulin as a way of estimating their GFR because the creatinine clearance is fairly normal. If creatinine clearance is way beyond normal, then you would probably need to do inulin clearance as a way of getting a very accurate measurement of filtration. Reabsorption, glucose clearance could be used because glucose is filtered and normally, at least in non-disease states, completely reabsorbed. Therefore, the amount of glucose that ends up being removed is going to be a good measurement of how much reabsorption is going on. Secretion, the substance called PAH, which is abbreviation for para-aminohippuric acid. It is filtered and fully secreted but not reabsorbed. So if you have PAH clearance and you subtract inulin clearance from it, since inulin is a measure of filtration and PAH is filtered and secreted, if you take away filtration, the PAH clearance that's left, the value that's left from this calculation, will tell you how much was secreted. PAH can also be used to determine renal plasma flow. So in terms of diagnostic thinking about materials, in terms of renal function, for any molecule X, if it's freely filtered at the glomerulus, if filtration rate is greater than excretion, there is a net reabsorption of it. If the excretion rate is greater than filtration, there is a net secretion of it. If the filtration and excretion rate are the same, that substance passes through the nephron without any reabsorption or secretion. If the clearance of that substance is less than inulin clearance, there is a net reabsorption of that substance. If the clearance of that substance is equal to inulin clearance, that substance is neither reabsorbed nor secreted. And if the clearance of that substance is greater than the inulin clearance, there is a net secretion of that substance.